Okay, welcome to Chapter 11, Principles of Resuscitation. The chain of survival. So what is the chain? It's immediate recognition of a cardiac arrest and activating the emergency response system. Early CPR with emphasis on chest compressions. Getting them defibrillated as fast as possible. Effective ALS and integrated post-cardiac arrest care. So cardiac arrest is when the heart stops beating or is in a rhythm unable to support life. So arrest is recognized and 911 is called. CPR is immediately initiated with emphasis on quality compressions. And then defibrillation, which shocks the patient's heart. We carry AEDs, automatic external defibrillators, and they look for certain rhythms. They're looking for ventricular tachycardia, or VTAC, and ventricular fibrillation, or VFib. That's the only two rhythms that an AED will shock. And from the studies of the American Heart Association, what saves lives in cardiac arrest is quality chest compressions and early defibrillation as fast as possible. And that's what saves them. So advanced life support, ALS, pre-hospital emergency care. So we can use intravenous fluids, drugs, cardiac monitoring, defibrillate, intubation, other advanced procedures, all sorts of stuff that EMS can do. And then the post-care, if we get them back after cardiac arrest, we've got to do, there's all sorts of different things they're trying now. Therapeutic hypothermia, cooling the patient off, things like that. So what's the role of an EMR in the chain of survival? Our role is we're most likely going to be there first, so we need to get chest compressions going. Probably early defibrillation because we have defibrillators. The benefit of advanced care is more advanced procedures, but like I said, what saves lives is early defibrillation and quality chest compressions. The heart is the center of the circulatory system. It's a pump that moves blood around the body. So the heart is our pump. So what causes cardiac arrest? Any number of things. Probably the most common is heart attack. Signs that they're in cardiac arrest is unresponsive, no breathing, no pulse. CPR is external chest compressions and ventilation. We do the chest compressions to circulate the patient's blood volume. And the reason we want to circulate the blood is because the blood has the oxygen in it. We need to get that to the brain to slow down the onset of biological death is when they become brain dead. Make sure their airways open, ventilate the patient, get more oxygen into their blood. How does CPR work? So compressions cause increased pressure in the chest cavity. It forces blood out of the heart into the arteries and circulate to all parts of the body. When compressions are relaxed, pressure is released, so then a vacuum is created, causing the blood to go back into the heart. And then breathing provides oxygen to the patient's blood. I think of the heart as like a sponge. I don't know if I've mentioned this before. So when you're squeezing it or basically doing a chest compression, you're squeezing all that water out of the sponge, right? And then when you let go, you're allowing water to fill back into that sponge. So that's the same idea when we're doing compressions on the heart. So you can see here's a picture. So the pushes the heart down, kind of squeezes it, which forces blood through the system. So when do we begin it? That's a really good question. A lot of people, hesitate because they're like, well, when should I? At what point do I decide to do compressions? So if they're unresponsive, not breathing, and don't have a pulse, obviously, check for a pulse in the neck, the carotid pulse for an adult and a child. If it's an infant, do the brachial pulse, which is basically in the bicep. If you can't locate a pulse, activate 911, get an AED, and begin chest compressions. So the AHA will tell you that it is far better to give compressions to someone that doesn't need them than it is to not give them to someone who does need them. So if there's ever any question, start compressions. Here's a picture. He's checking for a carotid pulse. And here he's checking for the brachial pulse. So how do we locate where we do compressions? So we want to place the patient in a supine position or face up. We're going to kneel at their side or their shoulders. Quickly remove clothing that may be covering the patient's chest. So right here, here's an example. She's kneeling at his side. She's getting ready to do compressions. Place the heel of one hand on the center of the patient's bare chest, right between the nipples. Put the other hand on top of the first. Like so. All right, so keep both knees on the ground, shoulder width apart, deliver compressions straight down. So get up, lean over them, basically, and make sure you're releasing the pressure on the chest. Provide 30 sets of compressions and pause briefly to provide 2 breaths. When you're doing CPR, always remember you want to allow full chest recoil, which means you're allowing that sponge to fully open up to get as much blood or water in it as possible, and then you're squeezing it. But what we don't want to do is we never lift our hands off the chest. So after every 30 compressions, you want to breathe 2 times. This should take you no more than 10 seconds. Deliver each breath slowly over 1 second, and just make sure the chest deflates. Don't overventilate. So we're only looking for that slight chest rise, and then we move on. Here she is ventilating the patient with a mouth to mask technique. So rates and ratios of compressions and ventilations. So we want to deliver compressions at a rate of at least 100 per minute. Okay, we never want to interrupt compressions for longer than 10 seconds. There's that 10 seconds. That 10 is golden, right? We don't suction for longer than 10 seconds. We don't stop compressions for longer than 10 seconds, and we don't check for a pulse for longer than 10 seconds. So we give 2 breaths for every 30 compressions, and each breath is over 1 second. Effective CPR is when your hands are centered over the chest, the lower half of the sternum, go at least 2 inches at a rate at least 100 per minute. The correct rate according to the AHA is 100 to 120 times a minute. There's a lot of free metronome apps you can get on your phone, which is interesting. So if you download a metronome, or if you're musically inclined, which I wish I was, you may have a metronome at your house. You can set it to 120, and you can see how fast that actually is to compress the chest 120 times a minute. So let's say we respond to a local gym and find a 50-year-old male who had suddenly collapsed. Using an adult mannequin, demonstrate how you would proceed. So we don't have a mannequin, unfortunately, since we're doing this all online. But what we're going to do is, so say he's collapsed, we're going to get him to an open area on a hard surface, and we're just going to look, listen, and feel for airway, and check for a pulse no longer than 10 seconds. If we don't feel a pulse, even if he has one, but we don't feel it, we're going to start compressions, because it's better to give them to him if he doesn't need them than it is to withhold them if he does need them. Adult and child CPR. There are some differences. So with one rescuer, you're going to position the patient face up on a hard surface, or that is the supine position. Check to see if they're responsive, check for breathing, check for a pulse, no longer than 10 seconds. Right here, hey, sir, can you hear me? Can you hear me? Can't hear me, so he's looking for chest rise and fall, checking for a pulse. So no pulse, or maybe he doesn't think he feels one. So he's going to start compressions, 30 compressions. As soon as he's done with 30, he's going to open the airways in the head tilt chin lift or the jaw thrust. He's going to give 2 breaths, but this is going to take no longer than 10 seconds, and then he's going to go right back to compressions. So if they have a carotid pulse but no respirations, provide one breath every 5 to 6 seconds, which equals out to about 10 to 12 breaths per minute. And normal respirations for an adult are 12 to 20. So to rescue CPR, this is obviously the preferred method. It minimizes transition time between ventilations. The person on chest compressions can count down as they're counting to 30. So you can go 29, 30, and then breathe. Breathe. Compressions right away. Should take no longer than 4 or 5 seconds. So if you have two rescuers, you want a compression rate of 30 to 2 for adults and 15 to 2 for children. And every 2 minutes, you want to change people doing compressions, because I don't care how tough you think you are, it is going to burn you out. You are going to be exhausted. So 2 minutes is typically 5 cycles, and one cycle is 30 compressions, 2 breaths. So here you can see where he's looking, he's watching the chest compressions. He's probably counting in his head. Hopefully this EMT doing compressions is counting 2, and then can let him know when to breathe. Right here, sir, can you hear me? Can you hear me, sir? Checking for a pulse. And back to this. So let's think about it. You and your partner respond to an apartment complex where a 56-year-old female has collapsed in the lobby. So what are we going to do? Let's make sure, well, she collapsed in the lobby. We need to find out, are there witnesses? How long ago did this happen? Was this a witness collapse? So immediately we would check for pulse, check for breathing. If we don't feel it, starting CPR right away. Infant and neonatal CPR. So an infant, that is a baby from birth through 1 year of age. A neonate is less than 1 month of age. So place them face up on a hard, flat surface, maintain the head in a neutral position, and in order to do that, you're probably going to have to put some padding under the shoulders. Because their heads are proportionally larger than their bodies, you lay them, their head forces their head leans forward and it pinches off that airway. See how right there, because the back of his head is so big, if he was laying without that towel there, it would force his head forward and possibly pinch off his airway. I don't know who forced their child to do this picture for him, because it looks like he's kind of upset about it. Opening the airway. If no spine injuries, just like an adult, head tilt, chin lift, jaw thrust if you suspect spinal injury. Look for chest rise and fall, and the abdomen, because babies are belly breathers. Feel for a pulse of the brachial artery, no longer than 10 seconds. So ventilations with a child. Open the airway with a barrier device. You want to give one breath every 3 to 5 seconds. Be so careful not to overinflate the lungs on these little guys. Watch for that chest rise and fall. As soon as you see movement, that's enough air. Compressions to the lower half of their breastbone. For a single rescuer, you can place 2 fingers on the sternum. For 2 rescuers, encircle the chest with both hands and use the thumbs to compress. So here's the 2-finger method for an infant. That's if you have a single rescuer. If there's 2 of you, when one person's managing the airway, this is the preferred method. You can get them, get some pretty good compressions in this way. All right, so compression rates, at least 100 to 120 per minute. For a single rescuer, it's 30 to 2. For 2 rescuers, it's 15 to 2 for kids, because they need more oxygen, so we need to breathe for them more often. For a neonate, which is birth to 1 month, it's almost always due to inadequate breathing or asphyxia. So the ABC sequence is recommended, and keep them warm. They can't regulate their temperature like we can. So let's say we're first on the scene at a home where a hysterical mother is unable to awaken her infant. Using an infant mannequin, demonstrate how we would proceed. In the process of delivering CPR, another EMR arrives, demonstrate how you will continue efforts. So immediately, if you're arrived by yourself, you're going to take that kid and you're going to start those chest compressions with 2 fingers, right? Going to make sure they're on a hard surface, and let's make sure that they're not breathing, they don't have a heart rate, and then as soon as another rescuer arrives, have him take over compressions by doing the thumb method around the chest. So possible complications. If ribs crack, don't stop CPR. That's most likely going to happen. If you've ever done compressions, you're going to hear a lot of cracking. Reposition the hands properly and resume CPR. Fractured ribs will get better, but it's not going to matter if they don't come back from this, because stopping CPR doesn't do anybody any good. They're going to die. So I'd rather have them have broken ribs than be dead. Don't force excess air out of the stomach. If they vomit, stop CPR and just let it drain, get them suctioned. All right, so what would happen if blood were impeded in its flow, like the heart chamber not working properly? Well, obviously they're going to go into cardiac arrest. All right, moving the patient. Place cardiac arrest patient on a long spine board when available. A lot of PED boards have like the head already dropped down for you, but it also gives you a hard surface to do compressions on, and it makes moving them really easy. Trauma, severe injuries to the face, crush injuries to the chest, head, neck, and spine injuries. These are all well and good, but we've got to do CPR, because if we're not doing CPR, it doesn't matter what the injuries are. So, like we mentioned before, put them on a hard surface. They've got to be on their back. Try to move them so their head stays in line with the body. Don't delay CPR to stabilize the neck and spine, because we've got to get their blood pumping. Hypothermia. No attempt made to rewarm the patient in the field. So we aren't going to try to rewarm them if they're in cardiac arrest and they're hypothermic. Resuscitation should continue until the patient can be rewarmed. We've all heard stories of patients that were hypothermic. Basically, their body goes into like some sort of cryogenic stasis. I don't know how the science behind it, but you can attempt resuscitation a lot longer when the patient was hypothermic. So we won't try to rewarm them. If they're alive, we're going to start warming them slowly, right? But we'll talk about this later, but if they're frostbitten, we don't thaw it out unless we know they won't refreeze. But in this situation, cardiac arrest, we don't rewarm them because we want to keep them cool. We'll let the doctors do that. So stopping CPR, when do we stop it? Medical director, physician at scene may order you not to begin CPR if there's obvious signs of prolonged death, so rigor mortis, pooling, things like that. But or DNRs, something like that. But unless we see the DNR, a physical copy, we have to treat them, so we have to start CPR. So continue CPR until the patient regains pulse, then provide ventilations only. Spontaneous pulse and breathing begin. So if you're doing CPR and that happens, stop. Or if equally or more highly trained members of EMS show up, they can give you a break, because you got to switch out. You're going to be worn out. We'll keep doing CPR until we turn them over to the hospital or the ambulance crew, or you are exhausted and no longer able to continue. A lot of times people ask, what if I'm alone with somebody and they pass? What if I can't keep going? Well, you just, hopefully we're never in that situation, but you can only do so much. Do compressions as long as you can. So let's say we respond to a local pond where a teen was pulled out of the water after falling through the ice. It is unclear how long he was underwater. He appears blue and has no pulse. Your partner suggests calling it and leaving the body with police until the medical examiner can arrive. What do? We tell our partner no, and we put him in the ambulance and we transport doing CPR, but not rewarming the patient. Okay. In order to be dead in that situation, his body has to be warmed to core temperature. Defibrillators change the world. So this is what saves lives. It gives an electrical shock that stimulates the heart to begin beating normally. Manual defibrillators interpret the heart rhythm, and ALS providers decide whether the patient should receive a shock. So the AEDs only shock two rhythms, VTAC and VFib. The manual ones, they can cardiovert, they can do all sorts of other things based on the provider's skill level. So what they're doing is they analyze the heart rhythm, they determine if it's one of those two rhythms, VFib or VTAC, and then they shock. So a common misconception and something they used to do back in the day and something you see on TV all the time is when, especially on TV, but they shock the patient when they're flatlined or they're asystole, right? Well, basically the AED isn't necessarily jump starting the heart from nothing, right? There has to be some sort of electrical activity in the heart for it to work. So what it is doing in VFib and VTAC is it's basically overriding those electrical impulses, telling them to be quiet, and hopefully allowing the heart's normal electrical, the SA node, to take back over. Here's a picture of some great AEDs. Basic warnings. So follow precautions. Only place an AED on a patient who's in cardiac arrest. Don't place it over a medication patch or implanted pacemaker. And make sure no one's touching the patient when it's analyzing. So let's talk about this for a minute. When the patient has their own internal pacemaker or defibrillator, the only thing we have to remember is don't put the AED patch on top of that. You can put it to the side, you can put it, just don't put it on top of it. If they have a medication patch, take the patch off, wipe that area off, wipe the excess medication off, and then just put the patch on. So, do not attempt to assess or shock a patient who is moving. Do not attempt to defibrillate a patient who is lying in water. Hopefully that's an obvious one. Do not attempt to defibrillate a child under 1 year of age. So let's talk about not shocking a patient who is moving. And also the previous slide mentioned not touching the patient. So when the AED is analyzing the rhythm, the reason we don't want to touch the patient is because the AED may pick up the electrical activity from the person touching the patient. And it may interpret that as a shockable rhythm or a non-shockable rhythm. So let's say the patient is in VFib, but it analyzes and it picks up the person's rhythm touching them and it says, hey, no shock advised, when they need to be shocked. Or vice versa. They don't need to be shocked and you're moving the patient around and shaking them around and the AD is like, oh my gosh, they're in VFib, you need to shock them right now. And you shock them and it stops the heart. So make sure you're analyzing them, the patient's holding still, and no one's touching them. So when do we place it? Make sure they're in cardiac arrest. If you don't feel a pulse, you don't feel normal respirations, you throw the AED on. So you obviously want to do it on the patient's bare chest. Make sure it's dry. Do it one at a time. Make sure they're firmly plugged in. Just like that. Luckily, that guy's not hairy, hardly at all. On really hairy people, you might have to shave, or if you carry 2 sets of patches, stick one on, rip them off really fast, and hopefully you take a lot of the hair with you, and then put the second set of patches on. Right there, he's saying, don't touch him. It's analyzing. And then whether they shocked him or they didn't shock him, they're going to go immediately to compressions. So operating the fully automated AED. So assess the patient's heart rhythm, determine if shock is indicated, charge to preset energy level. It delivers the shock, and many have voice and text prompts. Most of them have voice now. So analyze the rhythm, advises if shock is necessary. Some models require the rescuer to push a button to begin analyze. I don't think any of the ones that we carry, or at least the ones that I've seen, require you to press a button to analyze. It just automatically says it's analyzing, and it'll automatically charge, but all the ones I've seen require the rescuer to push a button. Potential problems. The cables may be loose, poor attachment of pads, hairy chest, like I mentioned, wet chest, medication pads, error messages, and alarms. So sometimes they question you on the order of operations for an AED, and your answer may actually just be turn it on. So the first thing you do with an AED is you turn it on. And then the next thing you do is apply patches, because they can't do anything without the patches on. Quality assurance. Focus on your SOPs, right? So make sure you know your agency's guidelines, their SOPs, your protocols. Make sure we know how, our protocols are how Dr. Grow wants us to operate, so that's how we need to do it. Always make sure their equipment's properly maintained, which our AEDs are constantly, they're serviced regularly. All right, let's think about this. You and your partner respond to a gas station where a 68-year-old man was found slumped over the wheel. Okay, so you remove him from the vehicle and place him on the ground and begin resuscitative efforts. So we start compressions. We apply the AED and we hear no shock to advise. What steps do we take next? Well, at this point, I imagine, because we start resuscitation efforts, we've already determined he has no pulse. So if the AED is saying no shock advised, most likely what's happening is he's not in VTAC or VFib. He's in another life-threatening rhythm or no rhythm at all. So he's either flatlined or he's in a pulseless electrical rhythm, which means there's electrical activity, but it's not mechanical. There's no pumping of blood. So the best thing for him there is 2 minutes of CPR, and then the AED will tell us at some point to stop to analyze the rhythm again, and we'll just go from there. Best thing for him is CPR at that point.